Now I am pleased to introduce Scott Wolfe. Scott Wolfe is Executive Director of the Canadian Association of Community Health Centres, where he is responsible for the association's overall operational management. The association works with community health centers across the country on various research, policy, healthcare services, and advocacy initiatives aimed at improving access to appropriate healthcare and social services for all residents of Canada. Scott is also coordinator for International Federation of Community Health Centres, whose secretariat is based in Toronto at the Canadian Association of Community Health Centres. Prior to joining CHC in 2010, Scott was social policy advisor from 2004 to 2008 for the Alliance of Healthier Communities, formerly Association of Ontario Health Centres, during which time Ontario networks of community health centres doubled in number and reach throughout the province. He also served as previously as Director of Global Health Policy for the International Association of Providers in AIDS Care and Communication Advisor for Pan America Health Organization, World Health Organization. And Scott lives in Toronto with his partner and 3 children. Thank you so much for fitting us in, Scott, and welcome.
There we are. Hi, everyone. Thank you very much for the very kind introduction and the generous invitation from the organizers to present today. Pardon me as I try to get this. There we go. It's just a bit of a lag. I hope you can all see me and the first slide here in my deck. Yeah, so I'd like to first thank the organizers, not only for all of your work in putting together the conference this week, but also for the invitation to myself and the Canadian Association of Community Health Centres to speak to participants. I hope you've had valuable sessions so far, and I hope I can contribute some additional value. I see this as a conversation, and I look forward to the opportunity to work with organizers, with members of your working group on integrated models of care moving forward to see how and where we might collaborate. And I provided my contact information there via Twitter and at the end via email. I'm open to questions if you have any ongoing questions moving forward, or would like to explore opportunities for collaboration, be it at the national level or more regionally. Before I jump in, I'd just like to talk about context internationally as well. I think I focused my slides and most of my comments on the Canadian context, but as you heard in that very generous introduction, we also at the Canadian Association of Community Health Centres house a very small, emergent international federation of community health centres, which speaks to the fact that this model of care has taken root in many, many places around the world. In terms of its global history, and I'll tell you more about the community health center model for those of you who are just hearing about it for the first time. It dates back actually over a century. The first instances that we're aware of something that we would today qualify or consider a community health center took root at approximately the same time in China, South Africa, and Canada. In 1926, the first community health center in Canada was established in Winnipeg, Mount Carmel Clinic, which was established by the Jewish community in that city, which was really taking into its own charge the need to provide services to an influx of immigrants to the city who are coming for work and who are being excluded from services within the community. The Mount Carmel Clinic was established in 1926. In the 1920s as well, via the John D. Rockefeller Foundation at the University of Beijing, another example of a community health center was established. And very shortly thereafter, in the community of Folela, a rural community in KwaZulu-Natal, South Africa, the Folela Community Health Center was established by a physician couple who was working in the local community to integrate care and base services not just on medical need, but a wide range of social factors as well. We have information and stories about that global picture at the International Federation of Community Health Centers, ifchc.org, if you're interested in learning more about the global picture. And I'd be happy to share some of that information afterwards. All to say that I feel the community health center model, and again I'll get into, is one that has a certain inherent virtue to it, which has led a variety of people working in isolation from each other in very, very different contexts to arrive at the same point, which is really the provision of an integrated array of services based in the community with community input, and that address not just medical needs, but really the lived social realities of a local community. Community health centers around the world go by many different names. They're not always called community health centers. In the United States, we have a network of over 12,000 community health centers that provide services to over 23 million Americans. In South Africa as well, there are community health centers in Belgium, in the Netherlands, in Thailand, in Francophone West Africa, and onward. You'll find examples of community health centers. And so I think it's helpful to start from that global perspective and say that, you know, there's something inherent in the idea of a community health center, and some of what I'll talk to you about in terms of what characterizes a health center that has, you know, come to be in many, many different places around the world as people grapple with the challenges of not only how to provide accessible healthcare services, but how to build health, how to build healthy communities, and how to improve health outcomes for individuals, families, and groups. So let me move to the next slide. There we go. You know, as I was initially reflecting on the idea of integrated models of care, and, you know, took note that the working group was drawing from the work of WHO, caused me to reflect on the fact that at about the same time, the conversation related to integrated people-centered health services has been part of a broader trend I've seen over the past few years to really bring to fore the idea of taking a system approach to the integration of services and policies that work to overcome silos and barriers and take a holistic approach to how it is we improve delivery of services, but also how we build healthier societies. And so the IMOC movement that's kind of grounded in integrated people-centered health services has something kindred with the social development, sustainable development goals that are being advanced by the United Nations, as well as the idea of primary health care itself, which is being advanced by WHO. And so this conversation, I feel, is at this particular time in history, while, you know, is long overdue, feels to have some momentum behind it. And there are themes that seem to be taking hold in different parts of our global networks and frameworks that I hope ultimately will help to, push this over sort of the tipping point to a point where more governments globally, and certainly here in Canada, governments, you know, are moving to the sort of integrated systems that we that we need. And and so you as allies, we all, and the working group on integrated models of care will have a bit more fertile ground through which to do our advocacy over the coming months and years. So community health centers differ across our country in size, scope of services, types of funding, and often name, by virtue of the fact that we live in a decentralized federation where not only are responsibilities for planning healthcare, the responsibility, of multiple jurisdictions of each of the provinces, as well as the federal government with respect to certain populations. But also that, all of those provinces and other jurisdictions have gone about advancing primary care in different ways, and have, to certain degrees, chosen to support the idea of integrating primary care services with the other types of social supports that we know are equally, if not more important to health outcomes of individuals, groups, and communities at large. So we as an association have had the challenge over the last decade or more of really trying to bring some coherence to this network and movement that we capture under the umbrella of, in the name of, community health centers, understanding that there's a wide variation in terms of what that actually looks like on the ground, from one community to the next, and from one province and territory to the next, and have come up with a way of capturing that, so we know really what does fit into that network and that sort of that model, and what we can consider a community health center, and what is outside of that model. It's not to say that we believe that community health centers are the only way to go about delivering, primary care services. But as you can imagine, with so many other types of models, we have to have some sort of sense of what's in and what's out, and what is a community health center and what isn't. And so we've arrived at a definition across Canada that helps us to do that, and helps us to work with community organizations that maybe are a community health center but have never truly understood themselves as that, or might be on the verge of becoming a community health center. And what's entailed in that definition, as you see here, is that these are multi-sector health and healthcare organizations that integrate services, and that they adhere to the following 5 domains. That they deliver interprofessional primary care, meaning that not exclusively primary care delivered by physicians or by nurse practitioners, that it may be one or both in combination with other care providers. We don't define in our definition any more about those providers that, for instance, they all must be paid by salary, or they all must operate according to a certain type of modality, because that's often out of the control of community health centers themselves, and is the subject of provincial or regional health authority policy. And I'll touch on that towards the end of my presentation in terms of opportunities for advocacy. But really, it's just to say that to deliver effective primary care and to be considered a community health center, we believe that it really is a team dynamic, where an individual entering into the circle of care at a community health center will have access to more than one, generally more than 2 or 3 types of providers. That will include, as I said, family physicians, nurse practitioners, nurses, occupational therapists, physiotherapists, social workers, counselors, and so on. The second is that whatever those primary care services look like, they're integrated within the organization with health promotion and community well-being and development programs. That means that it's not just about what happens in the clinic, it's also about people's lives and realities outside of the clinic. And that in order to really wrap services and care and support around people, we have to be able to be in the community, and we have to be able to deliver support programs and look at the factors in the community that have an impact on health, if that's levels of poverty, levels of education, and so forth. So really that second one is about the integration across sectors. The third is that it's community-centered. What that means is having a community board of directors. So community health centers across the country are not-for-profit organizations, which are operated as not-for-profit corporations or as cooperatives. That means that they are independent from, have autonomy from government, are typically funded by government, but in terms of the accountability, the planning of services, and in terms of making sure that as organizations, they are responsive to the local realities and needs within a community. They are governed by a board of directors that is comprised of representatives from the community and from the region. It's usually a mixture of skills on that board, as well as representatives from the local community. You can speak to really to the local needs. Then the fourth characteristic is really addressing social determinants of health in an active way. I touched in the second point on, the need to really look at the social factors. This really means that at the level of services, at the level of advocacy in the local community, and maybe at the bigger picture of municipal level, provincial level, national level, that the community health center is mindful of and attuned to social factors that have an impact on health. So that various forms of social exclusion, for instance, and anti-oppression, be that racism, be it marginalization based on sexual identity, gender, other demographic and identifying factors. It can be housing and lack of access to affordable housing, poverty, education, that myriad of social factors that really is the 80% or more of what contributes to health or detracts from health that's really under the surface. If you think of the iceberg, primary care and the actual services are that 10 to 20% of what can impact health above the surface. That 80% below the surface are really all of the lived realities day to day that have an impact on our health. And so community health centers address these in an active way through policy and advocacy and through direct services and programs. And really, taking that up to a systemic level, the last point is taking action on health equity and social justice. It's recognizing that not only are these factors that impact individuals, but there are systems at play that perpetuate those negative factors, those factors that negatively impact health, and that it's the role of a community health center to really take a system approach and to address those inequities through through more of a system approach and through a commitment to social justice. So that, in a nutshell, really is what are the filters and the lens through which we would look at an organization and say, yes, it is a community health center. Now, I spoke to the idea of intersectoral integration. What does that actually look like on the ground? Well, the latest national survey that we did of community health centers, and we're due for another survey to get an update on statistics like this, but that we did in 2016, sought to identify the number of sectors in which CHCs are delivering programs and services actively. So this is through the community health center itself. In addition to direct services, CHCs will work in partnership with local agencies, et cetera. But this question sought to capture in how many sectors, such as senior services, primary care, housing and homelessness reduction, income support, working in the judicial system, et cetera, in how many of those sectors that we could identify based on sort of a comparator of how governments identify sectors at the federal level and at provincial levels. How many sectors are they actively offering services in? And we found that what is it there, that 78, confused by the color scheme for a moment, that 78% of community health centers were actually providing active services and programs in more than 6 sectors. So again, primary care, housing, food security, so forth and so on. I do have information that actually breaks down the extent to which community health centers are active in that variety of sectors, but it goes to show you that the overwhelming majority, 78%, are active in more than 6 sectors. 100% of community health centers are active in more than 2 sectors, which comes back to the definition, as I shared it with you just a moment ago, that if an organization is exclusively providing primary care services, even if it's doing so through a team of care providers working across disciplines, that alone would not characterize an organization as a community health center. And that's important to note because there has been a lot of progress across the country in advancing team-based care. You'll find that almost every provincial government, almost every territory, if not all of them, have some sort of active program to advance team-based care, recognizing that it's important to provide individuals and families teams of providers where you get the right care at the right time by the right provider. And that's progress, but far too frequently, that team-based care is decoupled from health promotion, community development, all of the other areas, sectors of activity where we believe it's critical to have touch points and to integrate with. Because if we don't do that, we're again missing so much below the surface of what actually contributes to what an individual is presenting with in clinic. And it provides an inadequate picture if you're just looking at the clinical setting of what the best remedies are to actually help an individual on their path to well-being. So the integrated nature of services across sectors is critical. Now, that's all fine at the level of an organization. You get a general sense. What does that look like from, an individual client's perspective? We have, various stories on our website and issue-specific stories, I think, are available from individual community health centers. And I'd be happy to share more of those. But I thought it'd be useful in the background materials for this session, for the conference, to share an example of a story. I hope that all of you have access to the background materials, but just in case, and just to sort of walk through a personal story of one individual's encounter with a community health center, I thought I would share with you Bernie's story. And I'm just going to read it from the background. For those of you who accessed this already and have read it, my apologies for the duplication. But I think for those who haven't had access to this case study or story, it gives a bit more of a practical sense of what it means to be in contact with a community health center. And my apologies, I'm looking down because I'm reading it to you. So Bernie's an Indigenous senior in Edmonton, Alberta, who first came into contact with the Boyle-McCully Health Center through the Community Health Center's Mio Waiawin Clinic. The clinic is a service provided by Boyle McCully Health Center on site at a local partner agency, the Edmonton Native Healing Center. Bernie first accessed the center's foot care program, and he did so for the first time in 2016. After having the wound on his foot attended to, he became a regular at the foot care program and gradually became comfortable enough to talk a bit more openly with Donna, one of the Community Health Center's nurses. Bernie had been homeless, living on the streets for 6 years. He had multiple chronic illnesses, including diabetes and heart disease. He was having challenges controlling his alcohol use, and he had no access to routine primary care. Building on the trust that Donna had established with Bernie, she connected him with Sandy, one of the Community Health Center's nurse practitioners, from whom Bernie now receives regular primary care. Sandy also referred Bernie to an ophthalmologist, and he's had cataract surgery as a result. Bernie has also been referred to a detox program, and at the point of writing this, and I truly hope that this remains the case for Bernie's well-being, at the point of writing this, he was many months sober. Through Boyle McCully Health Center, Bernie has also been connected to permanent housing with an inner city seniors housing program. And as a regular client of multiple other services provided by Boyle McCully Health Center, Bernie's at the center of a circle of care and one of support that's there for him when and hopefully where he needs it. Now moving on to more generally about Boyle McCully Health Center in Edmonton, their 13,000 plus clients, those that access services and programs at the Community Health Center, have access to wraparound care through an interprofessional team. This means chronic disease management, mental illness and addictions care, HIV care, hepatitis C care. All of those, for example, are integrated as part of regular primary healthcare services. The care team is comprised of nurse practitioners, nurses, social workers, family doctors, psychiatrists, mental health and addiction counselors, dentists, and outreach workers who work together with Boyle McCully's clients to address their needs at the right time and by the right providers. They also have a dedicated health advocate on staff, and the health advocate acts as a resource for both the staff and clients at the center in regard to housing, financial and legal issues, food and clothing issues, educational and employment opportunities, applications for government assistance, and more. In addition to Boyle McCully's health advocate, social workers play an essential role. Social workers are always on site at the Community Health Center's main location and are always able to help line someone up with services or to help them navigate services from a government agency or another social service agency in the community. If a client needs help with income tax as part of addressing poverty or low income, for example, the health advocate connects the client to a volunteer who can help with that. If a client is interested in finding work or going back to school, Boyle McCully Health Center provides support for resume writing, mock job interviews, and other support tools. And as needed, Boyle McCully Health Center will work with its clients on government assistance to establish third-party payment plans in order to guarantee that a client's rent get paid when benefits check goes out, or other forms of support to mitigate the chance that someone will remain or become precariously housed or homeless. There are other examples that go further into detail on the programs at Boyle McCully Health Center within that case study. I'll stop there just to give you a flavor of what that looks like from the individual perspective. But that's one story of a single client at Boyle McCully Health Center in Edmonton. What I'd say in addition, just to bring that back up to the level of community health centers more generally across Canada, is that you'll find that same sort of texture of personal support and personalized care within the scheme of the organization's services that's provided to individuals, families, and on occasion groups as well. Highly tailored to the realities in a local community. We often say that when you've seen one community health center, you've seen one community health center. meaning that there is a common theme and characteristics, as I pointed out, but that they really will, through support of their community-based board of directors and their multi-professional diverse staff, really attune the services and programs they deliver to what they're seeing in the local community. Now, COVID-19 provided us another opportunity to see how community health centers work at the local level, being nimble and adaptive in the face of emerging issues and quite complex issues. We conducted research during the early months of the summer just to find how community health centers had managed through the pandemic, and what experiences they'd seen at the level of their patient client groups, and what they'd done in response. We're really not surprised, I guess, but very encouraged to see that that 100% over the first few months of the pandemic, 100% of community health centers across the country who responded to the survey, and it was a high percentage who did respond, were doing outreach in the community to help provide information about what COVID-19 is, preventive measures, how to access services, and what to do in the event of local business closures, school closures, and so forth. Again, in this very emergent phase of the pandemic, 58% of community health centers across the country had pivoted in order to either operate an assessment center, operate as an assessment center to provide testing, or participating in local assessment and testing initiatives. And a very impressive number, 95% over the first few months, had been able to pivot and were now offering some scope of their ongoing services virtually. All of this points to the impact of community health centers in ensuring continuity of care. Obviously, there are certain enabling factors at community health centers that provided for their ability to do that pivot and to be able to ensure continuity of care. Some had resources at their discretion to invest in personal protective equipment, to retrofit their buildings, to go online, whereas others didn't. They may not have the funding. There may be barriers locally, such as lack of access to broadband internet service, which provided a challenge when it comes to providing services locally. But I think these stats demonstrate that community health centers were able to pivot fairly effectively, fairly broadly in terms of rising to the challenges of COVID-19. And you would have seen other examples of this sort of responsiveness more locally in Alberta, for instance, in Calgary during the floods several years ago, in Quebec many years ago during the ice storms, and again in Ottawa more recently during the ice storms that led to massive power outages and shutdowns of businesses and services for several days. And so it is that ability to be nimble, to have some organizational capacity to react and respond to emerging issues that adds value at a regional level, of having a community health center where individual providers, and group practices of physicians and other care providers may not be able to do that because they don't have that administrative organizational capacity.
Hey, Scott, sorry to interrupt. I know you still have some good content to get through, but if you could, we're just at the end of your time. I don't want to shortchange anyone else. Thank you.
I absolutely will. Thanks, Leah. You'll have access to my slides. So I think this is more evidence of that impact of continuity of services. So I'll just leave that up for a moment and roll to the next slide. This is from one community health center, again in Northwest Ontario, Norwest Community Health Centers, an example of the sorts of social services and supports that the center was able to pull together with a small $5,000 grant that we were able to facilitate for them in partnership with TD Bank's Ready Commitment, who provided a national donation to community health centers to do this sort of work. And it gives you a sense of the sorts of daily needs that a community health center can respond to, in addition to their ongoing programs when an emergent situation poses challenges to individuals who are often, in precarious work situations, inadequately housed, living check to check, and for whom having access to a bag of groceries can mean the difference between having children go hungry for a week or not. So again, you'll be able to come back to this slide, and we have more stories and cases at this website where we have a few videos, blog stories that tell stories from the front lines, as well as news articles that are curated there, if you want to get a bit more of a sense of the impact of community health centers during the pandemic. Now, again, I'm glad, since we're running close to time, that I touched on most of this sort of in the introduction. That community health centers are highly divergent across the country, not in terms of vision, mission, and goals, but really in terms of what they're able to accomplish based on the realities of our very fragmented healthcare system, the fact that at a policy and funding level, we're at a place where, despite the conversations that we are having here, and despite, I think, what patients know very well and want from their services, where healthcare is in reality dislocated from other sectors of services when it comes to how they're funded, who plans them, and so forth. And we have we still exist in a paradigm where curative medical services dominate. And so community health centers, despite their differences, are all sort of reactions and responses to the inadequacy of all of these barriers, silos, and fragmented systems, and are doing their best within the scope of, within the context of their local province, and within our national context to respond effectively to that. However, that requires responsive governments, and it requires the types of supports that enable the type of services that I described in Edmonton at the Boyle McCully Health Service Center, the ones that Bernie was able to access, and many other individuals who access Boyle McCully, for example, are able to access. So, as I said, again, these are examples of the challenges that we face, that most provinces and territories don't have any official policy or guidance for community health centers. There are some examples. For instance, Ontario and British Columbia actually have policies. They have provincial programs for what community health centers should look like, how they should be funded, and so forth. A large majority of community health centers don't receive core funding for their overall work. Some don't receive any government funding at all. They truly are grassroots local organizations that are patching together services through grants, through individual provider contracts, and so forth. And where core funding exists, and this is increasingly so even in leading provinces like Ontario and the city of Winnipeg, for instance, there's an increasing focus on just primary care and erosion of all of those other complementary services and programs, and the funding for those that's so essential in terms of contributing to health and well-being, particularly for individuals who face complex social and medical realities. And lastly, there just simply are far too few communities that have access to any type of community health centers. So those are some of the systemic and structural barriers. Now, my final slide, I'm almost there. What does that mean in terms of our forward-looking vision, and what it is that we can all look to achieve together and focus on together? Well, it really is to call on governments, both individually, so the individual provincial government, federal government, and municipal government, to think about funding services from a cross-sectoral perspective, but also to work across levels, because as you can imagine, community health centers, as very dynamic organizations, are doing work that falls under the jurisdictional responsibility of all of those levels of government. And so community health centers are making real on the ground the integration of services. That's very hard to accomplish when the policies and the types of funding that are available are a barrier to doing that. And so we need governments to think about operating from an intersectoral perspective, and we need to call on them to do so. It really means that, that again, the policy and investments should facilitate that and provide organizations with some administrative capacity themselves to navigate systems, but to support clients to navigate systems. And so that's what I mean in the second bullet there about having administrative and navigational capacity. Your family physician's office, even if it's a group practice, just doesn't have that sort of capacity to be helping clients who may be diabetic and require an adjustment to diet, but are living in poverty, figure out how they do that. And so we need organizational capacity to help clients find their way to food security programs and all of those other services that can help mitigate negative lived realities and to help overcome them. We also need, systemically in partnership with academic partners, but also looking at our partnerships with federal funders to really draw attention to measuring what matters. Are we just measuring procedures when it comes to primary care, for example, or to someone's access to a particular program or service, or are we measuring outcomes? And so we need a research agenda. We need an evaluation agenda that really focus on what matters. And that's what matters to people for their own health. But it's also assessing, whether in fact they, are progressing along a path of well-being. And my very last point really is that this can't be strictly top-down in terms of how we fund services for whom and where they're needed. We need community engagement. We need participation of individuals as clients of services. You notice I haven't used the language patient much. In the community health center sector, we tend to use the language of client, but what I mean essentially is consumers, clients, patients of services having an active role in providing input and feedback, and helping shape services through client engagement surveys, advisory panels, et cetera, but also at the level of governance. That we need that level of participation in terms of our services, not just primary care services, but our broader social services, to make sure that they really are attuned to local needs, that they are attuned to what people in the community want, and that they aren't static, because communities aren't static, communities evolve. And so having that participation enables community health centers to evolve over time as communities evolve. So I hope that resonated. I'm again happy to participate in Q&A and moving forward, invite ongoing collaboration to see if we can't move forward some of these policy and advocacy points that I think are in our collective best
So
interest.
we will be in touch, Scott. Thank you very much for that presentation.
And there I am. And thanks so much.
Excellent.